may want to come back and refer to this later. But largely, I'm very open to taking questions that you have developed from your study, things that you're concerned about, and or problems that you've had with any of the materials. So let's just go around the room, and I won't call on you, Junyan, because you haven't really started those. But Junyan, you have done quite a bit already and have progressed through several of the modules. What questions or things would you like to bring up?
Uh, sure. So first, I think I like the module because it's very it is organized very well. But for me, I don't have pathology, training experience. Sometimes I feel some of the slides, it's very difficult for me to, to diagnosis for them. Yeah, but anyway, generally. I for in that case, sometimes I will discuss with my friends for the diagnosis. Yeah, I can. For me, I think just for some of the module, but
Yeah,
not all of them. Especially, so many in the digital slides, you have to you preview all of them and make the diagnosis. For me, maybe I can catch up the major points, but for the mild morphological change, I cannot.
yeah. So I think that's a very valid point and question that a lot of people struggle with is when I first encounter a slide, how do I begin to develop a differential diagnosis? How do I approach that slide to understand and figure out what it might be? And I was thinking about that, and as we came to this session, that I think this is where it's so important to know histology, so you know what part of the body you're in as you look at the case, but also to understand the clinical history. So the approach to a mass lesion in the breast with calcifications would be very different to the approach to a mild diffuse abnormality on the mammogram or something of that sort. I mean, we know usually the biopsies are asking the question of, is this malignant or is this an infection or, so that becomes then the kind of the second category that I think of as I look at a slide is I try to decide, is this a mass lesion? Is it a tumor? Or is this an inflammatory or some other kind of process that's going on? Now, of course, there's not always a sharp distinction there. Some cancers, like lobular cancer, can be very insidious and infiltrative, not really forming much of a mass on the slide. And some inflammatory processes, granulomatous process and so forth, can form masses. So it can be a little bit confusing in that way. But I think that is a helpful distinction to initially think about that process. Then, as I maybe begin to center down on what the possibilities are, that's when I start running through the mental images in my mind. And how did those images get there? I think that's one of the key questions that you have to ask as a trainee. How do you develop that intellectual atlas of what things look like so that you can know or begin to put something into a category? And that comes by looking at lots of slides where you know what the answer is and seeing and so that's why we try to give you lots of digital slides to evaluate as many as we can. And also where the value of textbooks. So when I began my training, every day in our training, there was a noontime conference, and the attending pathologists would put together small clusters of slides of different cases for us to study as unknowns. They would tell us the history, ovarian mass or colon mass or 60-year-old with diarrhea or whatever the history was, and then give us the slide to look at and to begin to try to sort that out. And very often, we would then look at those and go, I don't know what this is. And we would pull off one of the textbooks, oftentimes an atlas of tumor pathology, for example, from the AFIP, or, the atlas of gynecologic cancers or whatever, and begin to compare pictures just to look, does this look like this? Does it look like this? Does it look like that, sort of thing, and run through that. Well, now we can learn in a lot of other ways using the digital resources to do that more quickly and so forth. So, for example, I'll share my screen here with the Digital Pathology Association, and I would encourage you to join the Digital Pathology Association as a trainee or as a person from a developing country. You can join the Digital Pathology Association, and one of the things that does for you is that it gives you access to this service, which is the Digital Anatomic Pathology Academy. And this, the value of this is the access to the slide library, as well as a place, if you have digital slides yourself, to upload them and store them. And so this slide library can be a very, oops, it looks like I've got to log in. So this is the Digital Anatomic Pathology Academy. When you join DPA, you get access to this, and you can come here, as often or as whatever as you please. And so these public slides here have a whole host of different diseases. So if I was looking at, say, a pancreatic tumor, I might say, okay, could this be a ductal adenocarcinoma? And so that will then search all of those and give me an example. And then I can look at this case and say, gee, my case doesn't look too much like this. Mine's much less cellular than this. Mine's different than this. So maybe I should think of something else. Actually, I'm not sure this is a good example of ductal carcinoma. So sometimes you have to be a little concerned about that. But usually the slides in this library have been curated and are well represented. So let's come back and use a different example. Let's say we wanted to see a neuroendocrine. We wanted to see a neuroendocrine neoplasm or neuroendocrine tumor. It would give us several different options that we could then look at. So we say we want to look at this one and compare, and then you have that resource. Okay, here's what a neuroendocrine tumor looks like, at least this example. And because you've got several other things here, you might be able to look at different examples. Now, this is an interesting tumor just in and of itself, because you see we have lots of pink material here. Just based on my past experience, I would say there's a good chance that this might be amyloid and that this is an insulinoma, or an insulin-producing tumor that is oftentimes associated with the production of this kind of very pink material, amyloid. So that's one one way of approaching an unknown slide or an unknown case, is to find comparison options. And this is one that I think is a very useful way. There's another way to think about this and to approach that, which would be to use pathology outlines. Here we go. And that then allows you to here select the various chapters. So if, let's say, well, let's stick with the pancreas here. If we're in the pancreas, we can come to this pancreas chapter, and then we can say, well, this looks like an exocrine type of lesion. So here are the various types of tumors that we might see that have exocrine function. And so we can say, well, this looks like it's going to be more of a, maybe it's got squamous component to it, solid and glandular. So let's look at adenosquamous carcinoma. And then we can come here and see what the description is. And path outlines, of course, includes references to case reports, as well as what it should look like grossly, what the microscopic appearance might be, some images, which you can see in larger format here. Well, here's some mucinous cells, and here's more squamous solid elements. So that may be a good descriptor. And then it also provides clues as to the cytology, the staining results, and very helpfully, it usually will give you a differential diagnosis as well. Is this a pure squamous carcinoma, or is this a metastasis from another site? So that's a very useful way, I think, to approach an unknown case, is to think about what it may look like in the context of the history that you've been given, and then go looking for similarities until you begin to have a good match. And then, of course, you can, as you do that, you can begin to develop an idea of maybe what stains will be helpful for you to confirm or differentiate it from the other things in the differential diagnosis. Well, that was a long answer to your question, Chinyan, but I think it's an important process to think about. Kamalji, do you have anything you want to add on that?
I agree with you. I think there are resources. Path Presenter has this nice collection of cases, and pathology outlines is easily accessible. And I will just stress what you said, that clinico-pathologic correlation, and you gave an example of breast, mass lesion, what can make a mass, calcifications, where do I see the calcifications? I think we are living in a world now where every part of pathology is very specialized. And I guess you kind of have to find a balance when you're a trainee, where you, in first 6 months or 1 year, you learn basic histology, histopathology, develop that good grasp. And then you quickly get into this phase where you have clinical and pathology both correlation. So it's just, I think, just being just a person looking at a slide and making a histological diagnosis, I think can get you there, make a good pathologist. But if you add the clinical information, radiology, it would make you even a better, and you will understand the disease better, because really you are there to understand the disease. And you can also contribute to the bigger group of people who are taking care of the patient. So if you think as a part of a bigger group, then it will help. Yeah. And actually, I have Tien with me. So she's rotating at Rhode Island Hospital.
Oh, wonderful. Welcome, Tien. I'm glad you could join this way. I'm glad you connected with Kamalji.
Thank you.
Yeah.
So another thing I think that's important that you mentioned right there is that interaction with your colleagues and understanding the important distinctions for them. So in many circumstances, especially those where resources may be limited and so forth, you may not be able to do all the molecular or immunohistochemical testing that you would like to get to a single precise diagnosis. But you may be operating or you may be working in a system where that's not what's needed. That what's needed is a decision: is this a surgical disease? Is this a medical disease? Is this something that would, radiation would handle, and so forth? So you may just have to, like, for example, soft tissue tumors, in many instances, the decision is this a tumor that's going to be aggressive, have, a potential for spread, or is this a more self-contained process usually? And so is it going to be just a simple surgical disease, or is this going to be something that, could have been something else from metastasis or whatever? So just putting it into a particular category of a spindle cell neoplasm may be all that you really need to do in order to help your colleagues. Likewise, sometimes you do need to make important distinctions. So, for example, in ovarian tumors, it's not okay to just say, well, this looks like a serous neoplasm. You have to be able to tell them, is this a high-grade serous neoplasm or is this a low-grade serous neoplasm? Because the management and the prognosis for the patient in the immediate and long term will probably be different. And you get that information by joining in tumor board discussions to see what treatment protocols are needed, and to hear what their questions are that they're trying to answer so they can take the patient to the next step. So V, do you have any questions or comments you want to bring up in our open discussion?
I found my own problem when I learned the open module, that I encountered the very high quality material, and in my daily practice, the case material is not good at the learning material or the textbook, and sometimes there are like artifact or mis practice in, for example, like tissue specimen or staining or something like that, and make the case quite hard. If my daily practice would have the high quality slide like the textbook or in the open module, then I think the diagnosis must be much more easier.
Yes, there's no question that a good quality slide makes the diagnosis easier for us. Although having said that, pathologists' eyes, as they become trained, they actually become very adaptable to variable histologic qualities, coloration of the stain, and so forth. That's not true when we start applying AI algorithms. Those become very sensitive to different staining and coloration issues that can be quite confounding if they're not controlled. But you raise a very important point, and that is that as pathologists, there needs to be a quality control program. And we alluded to this issue in the boot camp module, that you need to become familiar with some of the quality control issues that are present in histology. And at least in most Western practices, the pathologist is the director of the laboratory and therefore responsible to see that quality practices are followed and to provide the feedback to the technical staff to help them do a better quality job. I think there are several key variables that we often complain about most, and one is fixation, incomplete fixation or inadequate fixation. As you know, formalin only penetrates at a very slow rate into tissue, and it doesn't go through serous membranes very easily. It doesn't go through thick, solid muscle very quickly. So in muscular specimens or fatty specimens or any large specimen, we have to do a dissection or a preparation to help get good fixation in a timely manner. So in our laboratory, if we receive a large colon resection or a hysterectomy or something that we know we may not be able to dissect for a few days because of the workload, we will nevertheless work to open that specimen and expose the inner portions to formalin in a more urgent manner, so that it has then time to get good fixation before we have to do the definitive sectioning. Likewise, adequate volume of formalin is also important. We don't want to waste it, of course, but we want to have enough fixative in the sample that we can get thorough fixation. And then, of course, there are other aspects of the processing, cutting, sectioning, staining, where there are other variables that you need to be aware of. So the quality of the xylenes, for example, in dehydrating the sample as it's processing. If the xylene is contaminated with water, it won't dehydrate sufficiently. So the solutions in the processors have to be changed regularly to ensure that they'll do what they're intended to do. And so forth. Similarly with your stains and so forth, sharpness of the blades and all those kinds of issues. I will say that we are in discussions with the National Society for Histotechnology to share a module of instruction in histologic techniques that could be adapted for pathologists to understand, and also could be used to provide feedback to your technologists. So that's we don't have that yet, but it's coming. But I know that it is something that's important to be thinking about. Of course, also, it just takes good practice and high standards to achieve that goal of good quality technical preparations.
And I have one more question. I want to ask about your hospital. When we ask for ancillary testing, in my university, if we cannot make the definite diagnosis, and we ask for ancillary testing like immunohistochemistry, the process is that we have to make some diagnosis in the report, then tell the clinician that we need more tests to confirm the diagnosis, and the clinician will explain to the patient that process, and then we can run the ancillary testing. If luckily we can resolve the definite diagnosis, that's fine. But if not, we ask for more marker, more stain, and the process had to be repeated. That we ask the clinician, and the clinician have to re-explain to the patient, and sometime the pathologist, to save time, they run more marker at the first time to prevent that practice happen. But if we ask more marker, there would be more that cost more money at the patient, and usually some patient doesn't have health insurance pay for that or pay partly. But if we run step some marker and I don't know how to explain that. If we save money, that we only run some limited marker to have the diagnosis, it will take time of the patient. And I want to ask in your hospital how you manage that things.
Yes, I think we need to practice cost-effective medicine, and so choosing the best markers that we can, and the ones that are truly indicated is best. And that, of course, as you've indicated, sometimes is counterbalanced with the time delays. The system of payment, obviously, in Western countries is different than it is in developing countries. And the degree of autonomy that the pathologist has may be different. But we also have to be sensitive to those economic issues. We have a little bit more leeway in terms of ordering the needed markers, in that we generally have license to do that. What we may not have always have the privilege of doing is the ability to order, say, very expensive molecular testing that's going to be several $1,000s or something like that. But even, very often, say, if a FISH test is needed, say we're trying to demonstrate that this is synovial sarcoma, and we want to order a specific confirmatory fluorescence immuno in situ hybridization test or FISH test, we can order that on those cases. Sometimes when we order those, we have to send it to another laboratory, but we have a contract relationship with that laboratory to do that. And they may ask for a copy of our pathology report. So we may at times issue a preliminary report that says, this is a, monomorphic spindle cell neoplasm, and the differential includes synovial sarcoma amongst other possibilities. And we're awaiting confirmatory FISH testing or something of that sort. Those are the kind of approaches that we take. Sometimes we can reach a presumptive diagnosis, or say something that, this is what the diagnosis is at this stage. We have additional studies that are pending, and we will amend or addend the report when those additional studies become available to us. So there is some ability to update the report when we get additional studies back in our medical record. In general, the decision to pay for a test is not so much the patient responsibility, although sometimes the patients make that choice, but is very often controlled by the insurers. And since many patients, older patients, have a government-sponsored insurance program, they have certain rules that have to be complied with as to when that can be ordered, how often it can be ordered, those kinds of issues that come into play. And very often those decisions are made more by the clinician caring for the patient rather than by us per se. Kamaljeet, you want to add anything more on that process at Rhode Island Hospital?
Yeah.
So yeah, I think we are living in a world where additional studies like molecular studies are frequently needed. And then, an example that I can think of is a gynae tumor. So we sometimes we don't do POL-E testing at our site. And now right now, endometrial tumors, they need more testing. Sometimes we are like, okay, this could be POL-E. So in that case, we have to make a decision, like, do we need it right now? Or can the patient undergo an excision? And when would this particular test be needed in the management of the patient, right? So I think that can help you. Like, do you really need it to make a diagnosis? And also a part is you, with all your training and education, you really have to think, can you make this a diagnosis without that test? Or as Dr. Hassel said, maybe preliminary test. And in a comment, you can leave that, okay, the differential diagnoses are so and so. However, this is favored and a molecular test can be done to confirm this diagnosis. So that's what we do in POLE testing. We say, oh, it's a high-grade endometrial tumor. However, based on these findings, we think this could be POLE mutated. So a molecular test is needed to confirm that. It can be done now, or it can be done on excision specimen, the hysterectomy, because the patient will undergo a hysterectomy. So those are the things where you can handle it.
I hope that helps. So Van Huang, any questions from your experience so far with the modules that you want to bring up?
Hi, doctor. Can you hear me?
Yes, we can hear you well.
Yes, I have a question that I just curious. Like, do you use like AI in your diagnostic work? And if yes, so in what way has it been helpful for you in making the diagnosis?
Yes, so that's a very good question. It's a very forward-looking question. In our current practice, we don't use AI routinely for any of our diagnostic work. And largely that's because we don't digitize our slides completely, so that we don't have ready access to the digitized slides. There are some practices which are routinely using AI for certain types of cases, gastric or prostate. Some places use it for breast. And there are defined algorithms that can be validated or have been FDA approved for use in conjunction with pathology review, not as separate from or independent of, but as a sort of a quality control or an adjunct to diagnosis. So in terms of routine practice, that's where we are now, but there are certainly in the next couple of years likely going to be tools that can be helpful to you when you're examining a digital slide, where you might be able to highlight an area and say, what other tumors what should I be thinking of here? The folks at Harvard have developed an algorithm or a tool called PathChat that allows you to interact with the algorithm about the portions of the slide, ask it to say what it sees there and so forth in a very meaningful way. And I think those kinds of algorithms will become useful adjuncts to differential diagnosis and evaluation in the fairly near future. I would say within the next 3 to 5 years, I think more places will have those kind of capabilities. There are other ways, however, where you can use AI now. So, for example, I have on occasion taken my own description of a slide, what I see, and the patient that I am evaluating, and asked Gemini, the Google tool, or asked PathChat, what should I be thinking about in a solid tumor from a 60-year-old man in the pancreas that forms glands? And very often that will give me some ideas of differential considerations. Or you can sometimes use it to ask about antibodies, for example, and it will query the existing literature and say, well, these might be the best antibodies to consider for further staining. A related tool that's been around for quite some time is called ImmunoQuery. And I don't know if you use this, Kamaljeet, but I use it fairly often, a couple times a week or a month, to say, these are my 3 differential diagnoses. What antibodies will be most specific to differentiate these 3 diagnoses? And it will give you a rundown based on the literature and its algorithm of which antibodies would be optimal to help you reduce or to help you differentiate those things. And that is very helpful if you are in a cost-constrained environment and you want to make sure you don't run everything and waste the patient's money or waste your antibody reagents to do useless stains that don't differentiate or don't differentiate as well as other entities. Kamaljeet, any other comments on AI in your setting?
So I am not using any AI algorithm. So my sign out is, glass slides. And I do digital sign out also for another hospital, and it's all digitized, all breast, but there is no AI platform. But based on my attendance at different meetings, I think it gets a little complicated because every hospital uses a different platform, and each platform need to have their own little AI tool to screen the slides. So I think there are some probably issues with licensing or what tool can you plug into a AI or digitized platform. So that's one thing. So yeah, so far it's limited, but as Dr. Hassel mentioned, this is probably going to be the future. I don't know when it's coming, but yeah, it will be here soon.
I think this is an important question as you start evaluating the possibility of using digital pathology in your practice and looking at what platforms will be, most robust. So as Kamaljeet said, some tools are very proprietary and you have to use their specific tool. Others will work well within a particular environment. So for example, some health records will allow you to view the digital slide directly within that electronic health record, whereas others you have to have them open in separate areas and do different things to go back and forth between them. So the whole software side of things can be an important consideration. And ideally, we get to the point where our data streams can pull together the digital data, clinical laboratory data, radiologic data to allow us to not homogenize, but to draw on all of that data to get the best information, best considerations. And that process of having things in different silos, different towers or different repositories that don't know anything about each other is one of the big problems that we're facing going forward. Is how do we bring all of those together and interconnect and query between those data sources. Okay, anyone else have some questions you'd like to bring up?
I have another question.
Okay, go ahead.
Yeah, this is an old issue, but I still want to ask. Like sometimes I find like 2 entities very similar. Like even after done the immunohistochemistry, like the many marker, but still hard to decide. So how do you like approach this case and come to the final diagnosis for patient?
So two tumors that are similar and have similar marker? No, I don't know if I understand your question.
Like if we have like if we have a slide and it have like two differential diagnosis and they similar, and even after then the marker it is still hard to decide. So how you come to the final diagnosis for patient?
Well, that's a very that kind of goes back to what we talked about earlier in terms of how you come to a final diagnosis. You have a you have to use both your experience as well as all the other tools that you've got. So if your immunohistochemistry isn't clear cut, and your morphology is a little bit overlapping there, and the clinical history doesn't point you one way or the other, then you may just have to say, give a descriptive diagnosis and say you can't distinguish between those two entities at this stage. And you may be able to suggest what further tests might be able to differentiate those. Of course, you can, obviously, one of the tools you have is to show a colleague. My experience is unique to me, and Kamaljit's is unique to him, and our experiences don't overlap completely. So having other people's perspective and background is very helpful. I always tell our trainees that pathology is a team sport, and you need to have lots of players on your team with different skills and different backgrounds to be able to do a good job for your patients, because a single solo pathologist can't do everything. So you need that teamwork there. And then sometimes there are just cases that don't fit into a particular category. So I had a very challenging case this week of a patient who had a history of an ovarian cancer. And then they presented with, now 13 years later, with lung masses. And they were asking me the question, is this the same as their ovarian cancer? And that's all I knew. Ovarian cancer, new lung masses. And so, of course, I stained these lesions with various markers to see if I could identify features that said, ovarian cancer. Well, it had some markers. It was hormone positive and CK7 positive, but it was negative for the more specific markers like WT1 or PAX8. It wasn't P53 mutated and so forth. So I said, well, this doesn't really look like an ovarian cancer, but we should compare the previous slides. Well, long story short, it was been over 10 years, so the slides had been discarded. We still had the paraffin blocks, and I had to have the paraffin block recut, and then looked at the report, which was in an older electronic health record. They could make it more complicated. But the bottom line, as I finally got a recut slide and looked at the report, I discovered that this ovarian cancer was not a typical ovarian cancer. It did not stain for those same markers that were now missing in the lung tumor. And morphologically, it actually did look very similar to what we had in the lung. So, you have to put the whole picture together. And I think this illustrates that oftentimes the best special stain is to look at the previous slides rather than trying to prove it through some immunohistochemical way. But it also, I think, emphasizes that some tumors will not always fit comfortably into the classical categories. This ovarian tumor did not fit comfortably in either serous carcinoma or endometrioid carcinoma or any of the other common epithelial tumors. it had lost some of those markers, or it didn't have those markers, and so it was kind of its own entity. And we have to be able to recognize that sometimes there are tumors that don't read the textbooks and don't always follow the rules that we have developed to assign things to different categories. So this was a very instructive case for me in that regard. Good question. Hard answer. Choranai, any questions from your end?
I'm not have a question.
Okay.
But I want to say my knowledge. Okay.
Okay.
Okay. For the good quality slide, depend on the fixation, time running, tissue processor, cutting, microscope cutting, very thin is easy, but thickness cannot be, cell overlap cannot recognize easy.
Yeah.
Coloration, HE quality, dehydration, deparaffin from the saline ametoxylin, it make a good quality. One mix whole tissues, but you can control the which one can mix. Example, cervical. Uterine cervical is a mix junction. It's a maybe a mix diagnosis because junction is a transform cancer zone. This is to make a high quality. If slide quality is not better, you can feedback to the clinic pathology technician to make the quality like this to make the high quality. It's like this. For when we read the slide, can make the clinical information carefully. Tissue bring out anywhere, which where, colon, skin, to make the diagnosis different or local different diagnosis. Clinical impression from the clinician, physician. Example, skin mask. Clinician suspect that BCC, but may sure BCC. Yeah. Like this. When you see, to remember benign or malignant.
Yeah.
It's a benign. Which is a benign? Tumor, inflammatory change, or example like this for the brainstorm diagnosis to make this. If have suspect diagnosis 2 or 3, you need IAC or immune scan for the different which one is confirmed diagnosis.
Yeah. Thank you, Choranai. We've just got a few minutes left. Sovandara, do you have any questions?
Yes, Professor, I have a couple of questions about lymphovascular invasion. So my first question is, how long do you spend looking for it? Assuming you see a lot of suspicious area, but you can confidently call it positive. And if my second question is, if you see lymph node metastasis, do you still look for the lymphovascular invasion? Thank you.
So I'll let Kamaljit answer that question.
That's a good question. So, and I discussed this with my residents in breast. So example is breast and gynae. So in breast, I think it's organ dependent. So you're looking for LVI, you need to know where to look. If you have a 2 centimeter, 5 centimeter tumor, most of the times you look at the peripheral edge, the leading edge where the tumor meets the normal breast tissue. And in that edge, the LVI will be near, so kind of neurovascular bundle. So there will be some muscular vessels. There will be an artery, a vein, and a lymphatics. So I go around the edge of the tumor. I pause when I see a muscular vessel, and I look for LVI. So those are the location in the breast. In gynae, same thing. You look at the, I think you can use the same rule at the leading edge of the tumor, where the tumor meets the normal tissue in the myometrium. That's where you look. And of course, there are things that can look like LVI, but they're not LVI. So tumor retraction can mimic LVI. So you want to make sure it's not retraction. Like there are some breast tumors that it's impossible, sometimes very difficult, like micropapillary type of carcinomas. And you will find micropapillary in many organs, breast, prostate, pancreas, lung, where it's difficult to identify LVI. And everybody knows that. But you got to, follow the same principle. Where do you look? You look at the leading edge near the small muscular vessels and see. Second question, is it important to check for LVI if a lymph node is positive? I think I would say yes, I still look. And there's possibility sometimes you think, well, the LVI must have happened a long time ago. The tumor is already in the lymph node. Maybe it was very limited. Now I can't find it. But there are implications, especially in breast. If you have LVI, you're adding the weight of poor, prognostic factors. So if you see it, I'll still look for it, even if there's a lymph node met, and report it, identified or not identified. And it's a little frustrating. I understand that there is a positive lymph node. I should see LVI somewhere, but it's okay. The next step would be in that situation, if you have anything that is suspicious, do immunostains. And there are studies that if you do D240, that's one of the common stain that I do, you may find it. Sometimes it's inconspicuous. Sometimes the tumor embolus is kind of filling and distending, and it's hard to identify as a distinct LVI. So IHC can help. Yeah.
Yeah, good questions. Niang, anything from your end you want to ask?
I think I'm good. It's
Okay.
very informative.
All right. Feng Hua, do you have any questions before we wrap up? Jian, anything from your end?
I'm good. I think I'm going to catch up and to learn more modules and see whether I can bring some good questions next time.
Okay, wonderful. All right, well, thank you everyone for joining us this morning. It's been, or this evening, it's been great to have you with us. And Wint, I didn't ask you if you have a question, but I'll let you work that out with, or Tinyan, let you work that out with Kamaljit there in Rhode Island. So we will see you next time. Thanks, everyone. Have a great day.
Thank you. Have a great day.
Bye-bye.